Good evening, everyone, and welcome to the Pancreatic Cancer Screening and Cyst Management Guidelines webinar. My name is Rachel Kostelnik. I'm the Product Manager for Endoscopic Ultrasound Scopes, Accessories, and Devices here at Olympus America. We have a few items we'll be covering this evening. Obviously, first, we'll do our welcome and introductions, discuss our Pancreatic Cancer Awareness Initiative, the Olympus EUS Complete Solution, and then we are exceptionally excited to hand things over to our guest speaker, Dr. Vanessa Shami of the University of Virginia. We'll be discussing pancreatic cancer screening and guidelines for cyst management. Then we're going to wrap up the webinar with a Q&A if anybody has any questions from the audience. This is our legal disclaimer. This presentation is for your general knowledge and background only. Endoscopic ultrasound is to be performed according to the standard technique and is left to the operator's experience and skills. Olympus makes no representation, warranties, or other expressed or implied warranties or guarantees regarding the accuracy, reliability, or completeness of this information. Proper attribution should be provided for any use of the information contained in this presentation. Under no circumstance shall Olympus or its employees, consultants, agents, or representatives be liable for any costs, whether direct, indirect, special, incidental, consequential, or otherwise, that may arise from or be incurred in connection with the information provided or any use thereof. Dr. Vanessa Shami is the authoring physician of this presentation and is a paid consultant to Olympus Corporation of the Americas. As many of you may know, March is Women's History Month, and Olympus is proud to bring you this webinar in partnership with Women in Endoscopy, an organization striving to champion the advancement of women through education, professional growth, and leadership development. Moving into the Olympus Pancreatic Cancer Initiative. The Olympus U.S. marketing team is passionate about pancreatic cancer awareness, as this disease state has impacted many of our Olympus family directly. We recently launched a patient-facing pancreatic cancer website with a few goals in mind. The goals of the website are really to raise awareness about pancreatic cancer, educate on the importance of screening for high-risk individuals, and educate on the role of EUS in pancreatic cancer diagnosis and management. This website address can be found here on the slide, but it can also be found in the resources section on your portion of the screen. In addition to our pancreatic cancer initiatives, Olympus offers a complete EUS solution for our customers. We deliver today's most comprehensive EUS solution with a robust portfolio of EUS processors, echoendoscopes, and devices. Please use the resources section on your screen to learn more about the Olympus Complete EUS solution and the wide array of product services and support that we offer. Now, the moment you've been waiting for, Olympus is proud to introduce our guest speaker for this evening, Dr. Vanessa Shami, FASGE. Dr. Shami is a professor of medicine and director of endoscopic ultrasound in the Division of Gastroenterology and Hepatology at the University of Virginia Medical Center. She completed her internal medicine residency as well as her gastroenterology fellowship at the University of Virginia. Subsequently, she completed an advanced therapeutic endoscopy fellowship at the University of Chicago. Dr. Shami has received numerous teaching awards, including the University of Virginia Department of Medicine Excellence in Teaching Award, and is an elected member of the University of Virginia Academy of Distinguished Educators. She maintains a busy clinical practice, which embraces her interests in Barrett's ablation, upper and lower endoscopic mucosal resection, GI oncology, and pancreaticobiliary medicine. Her clinical research has led to numerous publications, and she co-edited a textbook on endoscopic ultrasound. Dr. Shami served as an American Society for Gastrointestinal Endoscopy Governing Board counselor. I will hand it over to you now, Dr. Shami. Take it away.
Thank you, Rachel. It's truly a pleasure to be here. I first want to thank Women in Endoscopy, namely everyone, but Amrita, who's president, and Uzma Siddiqui, who's vice president, and the entire leadership. I really am excited to do this. And also Olympus for supporting this, because I think this is an extremely important mission. You know, pancreatic cancer is really near and dear to my heart in that I diagnose individuals several times a week with this dreaded cancer and have actually even had to diagnose friends. So whatever we can do to improve our screening and surveillance of cancers and pre-malignant lesions of the pancreas is extremely important. So I have financial relationships which in no way will influence my talk. So let's start off with pancreatic adenocarcinoma. It's the third leading cause of cancer in the US, and it's rapidly rising so that it's going to be the second leading cause by 2030. So that's staggering. Morbidity and mortality is still bad. I mean, 8% 5-year survival rate in 2020, and that's still pretty low. The death to incidence is 0.99, which means that if you are diagnosed with pancreatic cancer, you're most likely going to die of the disease. So when you take all comers who are diagnosed with pancreatic cancer, the majority of patients have no familial risk or known genetic syndromes. So these are individuals that are just hit with a ton of bricks. It's, oh my goodness, doc, what did I do? And the majority of individuals really have no risk factors. 5 to 10% have familial risk, and this is defined as at least having one first-degree relative and one second-degree relative. And then 3 to 5% have an inherited genetic cancer syndrome, which we'll go further into in a moment. So when we talk about the transition from normal to cancer, we talk about pancreatic intraepithelial neoplasia, or PANN. I'm sure you've all heard that term used over and over. If you look at the left box, you've got the normal columnar pancreatic tissue. It's actually epithelium. And with time, in somebody who's transitioning to cancer, that epithelium becomes more columnar, even more you can see how the diameter changes, and it's filled with mucin. The cells are still basally located. And then with accumulations of oncogene drivers such as KRAS and tumor suppressor genes such as P16, you start getting more nuclear variation, this papillary-like growth, even mitotic figures, and that's low-grade PANN. And then as time goes on, you get more and more cellular irregularity. Your nucleoli get larger. And then eventually, with more and more mutations, such as P53, the breast cancer gene, SMAD4, you get an accumulation of these mutations, and you end up getting invasive adenocarcinoma. So when you take all comers with pancreatic adenocarcinoma, if you look, they 90% of them have KRAS mutations. Again, it's an oncogene driver. And then you can see 80 to 90% of individuals have a mutation in P16, which is a tumor suppressor gene. And you can see P53, the percentage, SMAD4, and BRCA2. So it's amazing how these tumors just occur due to the accumulation of these mutations. Now, when you look at the high-risk groups, we look at familial pancreatic cancer, obviously the genetic syndromes, and patients with hereditary pancreatitis. And again, we're going to go through this in a moment. But, even with our advances in imaging, we're really unable to many times detect these PANN lesions. As good as we feel we are as ultrasonographers, those of us who do ultrasound, we really are not, it's not close to perfect at this point. It's because these lesions are almost close to impossible to detect. We're talking about cellular level. Fortunately, things that we can see are cystic lesions. So, we know that some cystic lesions will go on to cancer. So fortunately, we do have precursor lesions that we can see, and we'll talk about them a little bit down the line. So what is our goal? Why do we screen, or why do we survey? Well, ultimately, the perfect scenario would be we would prevent cancers altogether. That's an ideal goal, but really what we're doing is doing early detection many times, and we're with the ultimate goal to improve survival. You got to remember, when we look at these studies, sometimes there's lead time bias in that, if we're diagnosing these cancers early, is there a bias in the data? So keep that in mind when you're reading many of these papers. But again, our goal is to improve survival. So who do we screen? I mean, do we screen everybody? I mean, it's a deadly cancer. Obviously, I wouldn't mind getting screened myself. But the U.S. Preventative Services Task Force actually recommends against screening the average individual who's asymptomatic for pancreatic cancer. And the reason for that is there's really not a lot of data on the accuracy of detection. Again, PANNs there is data, but PANNs are hard to detect. There's a lack of data on improvement in disease-specific morbidity, mortality, or all-cause mortality. And there's potential harm of false positive results and treatment. So if I were to call a lesion a small mass, and the patient were to go for a Whipple procedure, well, that's that has a high morbidity and even a small mortality associated with it. So these are the reasons they recommend against screening patients who are asymptomatic, who aren't high risk, so who are average risk. So if you take all comers again with pancreatic cancer, we're not screening those that have no familial risk or genetic syndromes. What we are concentrating are on patients who have familial risk and those that have an inherited genetic syndrome. And again, if you can see, it's a slice of the pie, but it's not the majority of patients. Yeah, you really can't talk about this topic without mentioning the Cancer of the Pancreas Consortium, really led by Mimi Canto. I mean, she's exploded in this field and really done a lot of good. They first met in Baltimore in 2011, and it was really to establish consensus guidelines for screening. And then they met again and updated these recommendations in 2018. And you can, you should really look at these guidelines in GUT in 2020, and the references are there. But what they've done is they've identified high-risk individuals. And if you look at the left, you can see all the genes that are involved that when mutated can increase your chance of pancreatic cancer. You can look in the middle, you've got the common names of these syndromes and diseases. And on the right, you see the risk of pancreatic cancer. So the relative risk. So how many times does your risk go up? So if you look at like Peutz-Jeghers syndrome, which we all know as gastroenterologists are associated with hematomatous polyps, and that's usually what we're dealing with. But these individuals, I mean, they have a 132-fold increase in the chance of going on to pancreatic cancer. So that's significant. CDKN2As or familial atypical multiple melanoma syndrome individuals, 13 to 39 times. And then you can see the list decreases with time. So what they have decided as a consensus is that if you have Peutz-Jeghers syndrome or mutations of CDKN2A, then that's good. That individual should be screened. Makes sense. They're very high risk. Now, there is another group there that I didn't mention here that really, really is high risk as well. And since you guys can't answer me, it's PRS1, right? So individuals with hereditary pancreatitis, they have a 40% chance of pancreatic cancer over their lifetime. Then you have the other mutations, and so having the mutation alone is usually not enough. It's having that mutation as well as a family relative with pancreatic cancer. So say you have BRCA1 and mom had pancreatic cancer, well, that's a reason to go ahead and screen. And then finally, familial pancreatic cancer. And what the CAPS defined as a familial risk is at least 3 affected relatives on the same side of the family of whom at least one is a first-degree relative, or at least 2 affected relatives who are first-degree relatives to one another, of whom at least one is a first-degree relative. It's a tongue twister. And 3, if at least 2 affected relatives on the same side of the family of whom at least one is a first-degree relative. So this is an extremely important table. So we've identified who the high-risk individuals are. How should we screen and how should we survey? You know, is ultrasound, percutaneous ultrasound okay? Well, no. So EUS and MRI really have the highest sensitivity to detect especially small pancreatic lesions. It's not perfect, especially for lesions less than 1 centimeter, but it's the best test that we have. They both have low risk profiles. EUS obviously has a little bit higher risk than MRI, and they're really complementary. So, you know, it's important to know which tests we need to use when we're diagnosing or screening these individuals. So what you can see here on the left is an MRI with a dilated duct, and then here I'm showing an ultrasound video, and you can see a small mass, and this corresponds to that MRI image. And again, this is an individual who, you know, believe it or not, on MRI, they did not call a mass, but they did say they were suspicious for cancer because of that dilated duct. So this is how the two work hand in hand. So when do we start screening? I mean, you know, that's another really important question, just like you and I think about colon cancer screening. Well, if you have a familial risk, you want to start no earlier than age 50 or 10 years earlier than the youngest relative with pancreatic cancer. Makes sense. Genetic mutations wise, if you have BRCA2, ATM, you know, you can see there age 50. If you have hereditary pancreatitis or the melanoma syndrome, it's age 40. And then with Poids-Jaeger syndrome, it's age 30 to 40 because they can get cancer at an earlier age. So it's important to have these guidelines just with you. If you don't memorize them, it's okay. Keep a chart next to, you know, your office and then look at it. I mean, I don't have everything memorized either, so it's really handy to know. So what's the data for screening? Well, in this cohort of 13 screening studies totaling over 1,300 patients, screening was performed using pancreatic protocol CT, MRI, or endoscopic ultrasound. And what they saw is 18 cases of pancreatic cancer were found in over 1,156 patients at increased familial risk. So it's not, these numbers are low, but I always say if I'm one of the 18, I am glad that you screened me. And then out of the 161 individuals with average risk, no cases of pancreatic cancer were found. So again, you can see why we kind of target patients at higher risk. In the 8 studies, there was no procedural harm in 675 examinations that were done. So that makes you feel better, that these tests, albeit have some risk, but it's quite low. So CAPS and, you know, majority of individuals agree that these screening studies and should be done in a multidisciplinary fashion, usually at a place that has, you know, a tumor board where you have surgeons, radiologists, pancreaticobiliary surgeons. And so at the University of Virginia, we actually opened a high-risk pancreatic cancer clinic in 2013. Again, it's comprehensive high-risk pancreatic cancer clinic, and the goal is the same, is to prevent to prevent cancers and to detect them at an early age. And I can't take credit for this. Our nurse practitioner, Kathleen Hayden, she actually went to Hopkins with Mimi Canto and observed how she ran clinic and what she did to build a practice. And so Kathleen then recruited our pancreaticobiliary surgeons, those of us who do endoscopic ultrasound, the radiologists, et cetera. And 6:45 every Thursday morning, we discuss things in a multidisciplinary fashion, which is extremely helpful. And so if you're trying to start a clinic, how do you recruit the appropriate people? Well, you got to market. Connect with genetic counselors in the vicinity and surrounding areas, because they're the ones who have access to the patients and can coach them on, you've got this mutation. You may consider, screening for pancreatic cancer. Kathleen has a web page, an email link, and a lot of it is, again, word of mouth and patient referral. So when a patient is referred to us, we obtain medical records, imaging studies. Then we go in depth into, their history in clinic. That we do some blood work and talk about prevention, smoking cessation. We know that BMIs that are, greater than 25 or 30 have an increased risk of pancreatic cancer. So we counsel them about weight loss. And also we counsel them about getting, screened. I mean, there is a little bit of anxiety for some individuals. Some individuals say, oh, I'm glad I'm being watched, I feel better. And some individuals get anxious every time they undergo screening or surveillance. And then patients undergo EUS or MRI. If it's normal, then you repeat it in 1 year. If there's a finding of any sort, then we discuss it in a multidisciplinary tumor board. So we're going to shift gears a little bit now, and we're going to talk about pancreatic cysts, which again are very common, and that is the reason we talk about them. They're common and they can cause cancer. In fact, in a study of MRIs done for non-pancreatic indications, 40% of patients greater than the age 70 had incidental pancreatic cysts. So that's a pretty high number. And that prevalence goes up with age. You can see if you're older than 80, 37% of individuals had pancreatic cysts. And, 0.8% actually had pancreatic cysts that were greater than 2 centimeters. And that's sizable. It's the minority of cysts, but nonetheless, those are the numbers. So you and I, as gastroenterologists, as surgeons, what are we trying to do here? We're trying to really distinguish the bad cysts from the okay cysts, those that we allow exist, okay? So the mucinous cystic neoplasms and IPMNs are the ones that can turn into cancer, and we're trying to distinguish them from the benign ones, the serous cyst adenomas and the pseudocysts, and we'll go into them in detail. So when we're looking at these cysts, we're trying to differentiate them, and so we're looking at morphology. Are they macrocystic or microcystic? And we'll get into that a little bit more. Do they communicate with the main pancreatic duct? Because IPMNs, or intraductal papillary mucinous neoplasms, and pseudocysts tend to communicate with the duct, but the others don't. We look at cytology, histology, and do fluid analysis on those that we are concerned about. So we get a CEA, and that magic number, remember from Bill Brugge's cooperative study, I think it was a 2004, time flies, was 192. So that was the most accurate test at the time to tell you whether something was mucinous or not. We look at mucin, amylase, and at times molecular analysis. And that all can be done with endoscopic ultrasound. So sometimes we know that the diagnostic yield, or we do know the diagnostic yield of cyst aspiration is low, and it rarely provides us with a definitive diagnosis. So now we have, these microforceps that go through 19-gauge needles that can be used to actually sample the epithelium or the cyst lining. And that can help you tell whether it's what kind of cyst it is. It is, had 100% in Yang study concordance with surgical specimens and telling us what type of cyst it is. Keep in mind, you're just biopsying a fraction of the cyst lining, so it's not a perfect test. You're just biopsying a small portion. So let's first talk about serous cyst adenomas. Think of serous, S, and I've underlined that. And that's because it's got small compartments. Again, S small. It's very sponge-like when you look at it on imaging. It's got multiple small compartments. It also, S, classically, if you're lucky and it's diagnostic, have a stellate scar. So again, a stellate scar. This is what it looks like on EUS. Again, sponge-like. And they're lined by cuboidal cells. I wish there was an S in cuboidal, but there isn't. And they actually will produce glycogen. So these are glycogen producing, and these are benign cysts. And when we see them, we celebrate. They occur more often in females in the 6th decade of life. They're benign, really rare reports of malignant degeneration. When you aspirate them, they're bloody because they're hypervascular. They have a low CEA. Remember, they're not mucinous, so you would expect the CEA to be less than 192 if you listen to that cooperative study in 2004. Again, no mucin, and they have a low amylase because they do not communicate with the main pancreatic duct or with the pancreatic duct. Now we're going to do M, mucinous cysadenomas. These are what I think polyps are to colon cancer. But mucinous, they're macrocystic. They have classically large compartments. 20% of the time they can be microcystic, so watch out. Sometimes they can be. You can see here how it's macrocystic, large compartments on cross-sectional imaging by EUS. There's a large compartment with this septation. And they're interesting because they're columnar. In this one, you can see the nuclei arranged nicely at the base of the cells. But on the other side, they have overlying ovarian stroma. So the stroma actually has estrogen and progesterone receptors. So when you talk to our pathologists, and majority of people I think concur, these occur in women. And so people have looked into targeting these to treat them. So mucinous macro, they occur in females in the 5th decade of life. They occur in the body and tail. And again, they range anywhere from benign to malignant. Now, if you think of them, they're bad players. They produce mucin. They're going to have a high CEA. Since they don't communicate with the main pancreatic duct, their amylase is low. One thing I always like to do is if you're aspirating a cyst and if it doesn't come out of the needle, it means it's pretty thick. So I can blow out a little drop. And if you put a drop on a slide and put another slide on top of it, you can actually pick up the slides. You can see some viscous material between it. That can tell me that it's a mucinous cyst. The other thing is you can put a drop of the contents on your thumb and use 2 fingers. So that's the string sign, classic for mucinous cysts. Next, there are main duct intraductal papillary mucinous neoplasms. These are neoplasms that arise from the epithelium of the actual pancreatic duct itself. Here you can see a coronal view. You see a huge pancreatic duct. Huge, and you can even see within that pancreatic duct you can see some defects consistent with growth. I mean, this is a little bit of an exaggerated case, but this is, a classic main duct IPMN. Then you have side branch IPMNs, and all it means is that the main pancreatic duct is not dilated. So you can see clusters of almost grapes. This is not classic. Usually they're a lot harder. They're, one tiny cyst, and it's hard to see if they communicate with the main pancreatic duct. But in this one, it's nice in that the main pancreatic duct is completely normal, and you can see these cysts communicate with it. So these are the most common cysts that you and I see in clinic. And these occur in the 6th and 7th decade of life. They can range from benign to malignant. And if you aspirate them, again, they're potentially pre-malignant or players. So CEA will be high, greater than 192. They'll have contained mucin. And because, again, they communicate with the main pancreatic duct, they are high in amylase. So what is the annual risk of pancreatic cancer in side branch IPMNs? Well, in this review of almost 4,000 patients with side branch IPMNs, the overall risk of pancreatic cancer was 2.8%. Interestingly enough, in other data, and it kind of varies, the pooled cumulative incidence of high-grade dysplasia or pancreatic cancer for low-risk IPMNs increased quite a bit over time in a nonlinear fashion. So it's curious, truthfully, in 18 years of practicing lots of side branch IPMNs, I can recall maybe 2 that over time, I'm not talking about initially, I diagnosed them for surgery, but over time that I'm screening or surveying that actually have gone on to malignancy. But again, there are cysts out there, I'm sure, that I haven't followed up on, that have been followed up on elsewhere. So, there's a multifocal component too. So 40% of people have multiple IPMNs. So just like the other one I showed you. And interestingly enough, there is no evidence that the risk of malignant transformation is any higher in these cases. So what I usually do is I look at all of them, but I hone in on the largest one or the one that potentially has a mural nodule, et cetera. So keep that in mind. Now, this forest plot demonstrates the incidence of malignancy in IPMNs with mural nodules stratified by size. And in this study, there were 7 eligible studies included in this meta-analysis, and the pooled standardized mean difference was 0.791, really suggesting that a mural nodule size has a considerable ability to predict malignant potential in IPMNs. Anything solid, and you can see the red arrow, that was a malignancy, a malignant cyst. Anything with the villous growth, you got to worry about. That should kind of put off a red flag in your mind. So some pancreatic cysts will become pancreatic cancers. And so how do we identify which cysts are at risk for malignancy? And this is the $1 million question. And it's quite difficult. We all struggle. So let's visit the timeline of guidelines for the management of pancreatic cysts. And I'm hoping that I can simplify the concepts so that when you guys encounter a cyst, it becomes more doable because it's overwhelming. First, in 2006, if you look at the left in blue, there is the SUNDAI guidelines, or the International Consensus Guidelines. And all that means, SUNDAI, is the location in Japan that they had the meeting to come up with the consensus guidelines. Then in 2012, they met again in Fukuoka, Japan, and they revised their guidelines, and then they met again in 2017. So for our purposes, the guidelines we're going to look at for consensus guidelines are going to be from 2017. Next, the European guidelines came out in 2013. 2014 and were revised in 2018. You can see in green there. In 2015, the AGA guidelines came out. There was a lot of controversy about the AGA guidelines, and we're going to talk about why. But they are not as stringent, and they also recommend, and I say they, we recommend that if there's no change in a cyst after 5 years, you can potentially stop surveillance. And then finally, the ACG guidelines, which I find very similar to the consensus guidelines. For all intents and purposes, not to get us completely confused, I'm going to stick with the American guidelines for this talk. But I really want you guys to take these no-brainer concepts. You know, if somebody's symptomatic and we think it's cyst related, they are going to go to surgery. Okay. It makes sense. If they have an associated mass, there's not the question, they should go to surgery. I mean, maybe they'll get an EUS and a biopsy first, but they should be, you know, sent to surgery. And if you're going to consider somebody for surveillance, make sure that they are a surgical candidate, not, you know, with an ASA, not an ASA of 4. And they're willing to undergo surgery and or willing to undergo systemic therapy. Because if they say, absolutely, I'm not going to do any of these things, so doc, why should I, you know, even get surveyed? Well, they have a good point. As long as you talk to them and you document your conversation, that's extremely important. So this is a case. This is a 60-year-old who has a 2.5 centimeter incidentally found cyst. You can see near the tail of the pancreas. And the question is here, well, what do we do? You know, it's, again, anxiety provoking. Here you have a 2.5 centimeter cyst in somebody who's completely asymptomatic. Well, let's visit the consensus guidelines, or the international consensus guidelines. So first thing you're going to do is you're going to see if they have any high-risk stigmata of malignancy. Do they have obstructive jaundice? Does the, do we have any mural nodules or main pancreatic duct dilation? If they do, they should be referred for surgery. If they don't, they're going to it's considered having worrisome features. And these worrisome features include a cyst size greater than or equal to 3 centimeters, an enhancing mural nodule less than 5 centimeters, thickening or enhancing cyst walls, main pancreatic duct dilated but not quite over 10 millimeters, abrupt change in the caliber of the pancreatic duct with distal pancreatic atrophy, lymphadenopathy, increased serum level of CA19-9, and cyst growth rate of greater than 5 millimeters over 2 years. Now, I don't memorize all that. You can put this up on your wall. And if they don't have any of that, then you're going to survey them based on size. And you guys can read that there. Again, less than 1 centimeter CT MRI in 6 months, then every 2 years. 1 to 2 centimeters, they get a CT or MRI every 6 months, and et cetera, et cetera. So it's all size-based. Now, this guideline is extremely stringent in that they have been criticized for kind of quote unquote overdoing it, but it is very EUS based. I actually really like these guidelines. And if you look, EUS is a part of the algorithm. If we go back to our patient, they had no high risk stigmata. They had no worrisome features present. And the size of the cyst is 2 to 3 centimeters, right? It was 2.5. The recommendation would be a endoscopic ultrasound, so keep that in mind. Now let's go to the AGA guidelines, okay? Conceptually, the high-risk features are the same for all the guidelines, okay? Here you can see it's a dilated pancreatic duct, or a cyst greater than 3 centimeters, or a solid component. If you have any of those, in this guideline, you need 2. That's the difference between the last guideline and this. You need 2 high-risk features to go on to EUS-FNA. Now, if you have no high-risk features, then you go to MRI in 1 year, and then every 2 years for 5 years, and then you can discontinue screening. And so our patient in this scenario would go for MRI in 1 year. Because again, they did not have 2 high-risk features, they would go down that algorithm. Again, the controversy of these guidelines are twofold. First, they recommend discontinuation of surveillance after 5 years, and also you need 2 high-risk features to go down the surgery path. And again, these are just guidelines. Finally, we have the ACG guidelines, and these are very similar to the consensus guidelines. And what you can see here is, again, high-risk features, the same theme. You guys are getting it. Dilated main pancreatic duct size, pancreatic duct diameter, very important. If they don't have that, they go through a surveillance based on size, just like the consensus guidelines. So they're very similar. The only difference between them is this is less stringent in terms of the number of studies. And also you can see EUS is not in that part of the algorithm. So in our patient, they didn't have any high-risk features, right? And then if you go down, 2 to 3 centimeters in size, is the cyst clearly at IPMN or MCN? One can argue either way, but I said no, and so they would probably undergo an EUS-FNA. Again, this is to emphasize the consensus guidelines and the ACG guidelines are very similar, except surveillance is less intense with the ACG guidelines. So, this is a study which compares Cyst criteria from 3 published guidelines. And it just shows you here the 3 guidelines on the left. And it's actually it shows you that, sorry, I'm trying to go on to the next slide. That out of 44 out of 33 patients who underwent the AGA guidelines had high-grade dysplasia or malignancy that would have been missed. So in other words, when you're using the AGA guidelines, which are not as stringent, 4 cancers were missed versus none if you went via the route of the international consensus guidelines. However, keep in mind in this study, and it's worth reading, that fewer patients would have undergone resection using the AGA guidelines. So you're missing cancers, but you're getting less mortality with, surgeries. So very important, fewer surgeries. In this systemic review and meta-analysis of a total of 21 studies with over 3,000 patients for advanced neoplasia prediction, both the consensus guidelines as well as the AGA guidelines really showed similar but unsatisfactory diagnostic accuracy. So the authors recommend that the guidelines be really used as a broad framework for how we practice. And so even though it sounds a little discouraging, that's kind of how we all practice. We bring in clinical scenarios and use the guidelines accordingly. Now, our group recently published, this is Brian Sauer, one of my partners, a modeling study. Patients underwent surveillance for the AGA as well as the consensus guidelines. And based on our prior data, we assumed a 0.24% cancer rate over a 15-year period. And what you can see is the cost of the consensus guidelines was higher. So the cost per additional cancer identified was $1.2 million. So that's significant. The other thing that it showed was that the number of deaths were the same between the 2 groups. So if you take this modeling study and these patients and you walk them through the 2 groups, they actually had the same number of deaths, but patients in the AGA arm actually, died of pancreatic cancer, and those in the consensus guidelines actually died more of surgical death. So very interesting. You're kind of trading one for the other. So remember our 2.5 centimeter cyst. If you follow the consensus or the international guidelines, the patient would undergo EUS FNA. In the AGA guidelines, MRI in 1 year, and the ACG guidelines, EUS FNA. So this is not to say that one guideline is better than the other. Just keep in mind they are a little bit different. I usually will sit down, talk to the patient, and use common sense. But just to show you the EUS of our case, we decided to do an EUS. And what you'll see here, very interestingly, you can imagine, probably going to show you something if I can get the video to play. I think it's going to show us in a second. So we see a mass. So actually the patient had adenocarcinoma. So this is, again, not to suggest that one guideline's good and one guideline's bad. It's just, again, the closer you're going to look, the more likely you're going to find a cancer, but we also don't want to overdo it because we're going to be subjecting patients to the morbidity and mortality of surgery. So in conclusion, in terms of screening, pancreatic cancer screening is indicated in patients with genetic mutations and familial risk. Not in asymptomatic adults without a genetic or familial risk. MRI and EUS are complementary. I can say that at the University of Virginia, we use MRI because, EUS, because insurance companies will not pay for MRI unless we have a lesion. And I know it is state dependent. We really need better ways to detect pannins, so we can even avoid pancreatic cancers in many patients. In terms of cysts, use your brains and the guidelines. Don't survey if you're not a surgical candidate, or if the patient refuses surgery or systemic therapy. And really, despite the differences, keep in mind you're going to evaluate for surgery, or even, send them to an EUS person if the patient has a dilated duct, red flag, mural nodule, red flag, size greater than 3 centimeters, again, a red flag, or they have a positive, obviously, cytology or biopsy. So with that, I want to thank you so much. It's been a pleasure. And I look forward to answering questions.
Thank you so much, Dr. Shami. Very educational presentation. We actually do have some questions that came through in the chat here. Quite a handful, actually. So the first of those is, in your experience, what's the smallest lesion size that's consistently detectable under EUS, cystic or otherwise?
Yeah, that's a tough question. So you remember, EUS is very operator dependent. And it's also anyway, 1 to 2 millimeters, but these guidelines really are basing it off cysts that are 5 millimeters or greater. But you can find a 1 to 2 millimeter cyst on EUS, but it's not something that is very readily aspirable. So you can't aspirate fluid off of it. I would say 1 to 2 millimeters. And one thing is, if you do EUS, sometimes what I'll do for these screening procedures is, if I do a linear exam and I'm not happy with how I see the pancreas, then I'll switch to a radial scope. And then sometimes, believe it or not, I will find small cysts that I don't see with the other scope. So I would say 1 to 2 millimeters, but that's pretty small. That's on a good day.
Okay. Great. Thank you so much. Okay, next question. Do you screen if mutations are positive without family history of pancreatic cancer?
That's I knew somebody was going to ask me this, darn. So, you know, the consensus is that you don't need to. What we do in our clinic, or what Kathleen does when she meets with the patient, is she talks to them about their risk. And if the patients are anxious, we actually will put them through screening. And again, it's more than anxiety. It's also, you know, do they have other cancers? So we don't go exactly by the consensus guidelines, but I would not screen everybody who has BRCA1 or BRCA2 with no family history, because we would have hundreds of patients. So I don't know if that answers your question. So we do sometimes. I have to be, you know, truthful. And again, that's a little bit anxiety related. The other thing you got to remember is that you have to run it by insurance. So sometimes they actually can make the call of, this is not, you know, this is not something we're going to pay for. So ultimately the patient has to make that decision.
Got it. Okay. Thank you very much. Another question is, do you measure glucose in pancreatic cyst fluid?
I do not. I know Girish Mishra, and there's a few studies that are coming out. I think the data is still preliminary, so we don't know, but it's very promising. And I'm hoping that it surpasses our CEA, but I think it's not ready for prime time yet.
Okay, very good. All right. What has your experience with the microforceps been, and what does pathology say about the quality of this sample?
So a few things about the microforceps. First of all, it requires a 19 gauge needle. Sometimes, you know, especially if you have a smaller cyst, it's tough to negotiate that 19 gauge needle in there. Additionally, when the cyst is less than 1 centimeter, you're just not going to have, you're not going to have much success. So I've had variable results. I've had, results sometimes that are diagnostic and other times that aren't. You really want to see the tenting of the opposite wall when you open up the forceps and close them to know that you're actually getting epithelium. Our pathologists, the bigger the better. And obviously these are microforceps. So if it was up to them, they would want more tissue.
Okay, great. Thank you. And what is your approach in older patients or those with multiple comorbidities with pancreatic cysts? When would you not decide to survey or decide to stop surveillance? Are the surgeons involved in these decisions as well?
So there's never anything wrong if you want to get more people involved to get a surgeon involved, but I don't. I sit with them face-to-face in clinic, and I say exactly what I had said on that one slide. If we were to find pancreatic cancer, would you undergo chemotherapy? Would you undergo surgery? And the answer is clearly no. I document it, and I won't follow them anymore. But you've got to make sure that the patient's absolutely sure, and you've got to make sure you document it. And a 90-year-old's not a 90-year-old. In other words, you can have a 90-year-old who, I